Dr. Bansal.
Thank you, Joe. No relevant disclosures. Avoiding declaration in care, deceleration of care, preserving the opportunity for donation. So what we're going to talk is resuscitation of the patient, identification of potential organ donor, continued resuscitation and treatment of the patient, and consent for donor management. We'll talk about two types of donors that are that how we classify. First one is a DCD donor, which is donation after circulatory death. And then the second one is brain dead donor, that is donation after brain death. These two have a little bit of differences in the type of organs that can be obtained. From a brain dead donor, you can obtain obviously heart, potential heart, kidney, lungs, liver, pancreas, and small intestines. From a DCD, heart is generally not used because of the circulatory death and the warm ischemic time. So for multiple reasons, that's why it's not done. Yesterday we were talking about using the DCDs and all of those things for identification of brain death. So brain dead donor, increased intracranial pressure sufficient to impede the flow of blood to the brain, causing cellular death of the brain tissue or herniation. If you look at it, obviously normal, and this is no flow to the brain. So this is what we commonly use as brain flow studies to determine whether the patient is brain dead or not. Determination of brain death involves multiple steps. The steps includes, first is establishing irreversibility of coma, normal systolic blood pressures, normal thermic. You can't declare anybody hypothermic, absence of drugs, no severe electrolyte or pH imbalances to be present. Bedside neurological exam is the second step that establishes the presence or absence of brainstem reflexes and motor responses. And then finally, we do the apnea challenge. All the other testing that goes along with it, such as the cerebral blood flow, EEG, TCDs, it could be used in a variety of ways depending upon your own OPO or your own institutional policies. So I'm going to talk about a little bit about from our institution, from state of Louisiana. Brain death may be declared by any physician duly licensed to practice in the state of Louisiana. Obviously, caveat, you have to also follow your own hospital guidelines. Only one brain death note is required in the U.S. state. Pediatrics require two. Two physicians must declare brain death for organ recovery. However, none of those two docs can be part of the transplant team. Obviously, conflict of interest. Brain death statement must be clear without any conditions implied. Must be signed, timed, and dated. Any of those things missing will not be considered as a brain death certificate. What are the impacts of brain deaths? That's what we're trying to understand. What happens when brain death occurs to all the organs? Two things happen, and that's what changes the quality of the organs and the post complications of transplants that we sometimes start to see. Autonomic storm happens, that is a catecholamine surge. Second is the disintegration of the aerobic pathways. So starting with the autonomic storm, sudden increase in intracranial pressure happens. And sudden increase in intracranial, this is an initial period of increased parasympathetic activity, followed by adrenergic activity. Increased catecholamine release happens. During this time, they go through periods of ischemia, followed by reperfusion, sometimes resulting in cellular death and no flow phenomenon. What do we see on the EKG? We divided it into five. We've studied, most of these studies have been done in actually large animal models. And in the large animal models, we have noted that there are 5 stages of this. Stage 1 is, as we were talking about, the autonomic surge, parasympathetic phase, sinus bradycardia. Whenever your parasympathetic system is going to be stimulated, you have sinus bradycardia, sinus standstill, complete heart block, sometimes junctional escape. Patients die there and then. Second is the adrenergic phase, sinus tachycardia. Now the response is happening. The body's next mechanism comes, catecholamine surge happens. Catecholamine surge happens, and then you have sinus tachycardia. Multifocal ventricular tachyarrhythmia starts to happen. And at stage 4, we say once all of those things have happened, that we start to see sinus return of the sinus rhythm. With some ischemic changes, as we talked about, the cellular death can happen, sometimes resulting in no flow. So those ischemic changes can result. You may see EKG recovery with some abnormalities such as the J waves and the T waves. This is the effect of brain death on heart rate and mean arterial pressures, if you look at it. All of a sudden you have a sinus bradycardia followed by catecholamine surge, and then you start coming down slowly. Same thing happens out here. If you look at the mean arterial pressures, and gradually it starts declining. And if these patients are not managed properly, they become very hypotensive. That's why they say we give a lot of volume and still the blood pressures are low. You have to sometimes work on their sympathetic tone. That is, the peripheral vascular resistance have to be worked on. What happens on the hemodynamics of these patients? Significant increase in SVR happens initially and mean arterial pressures. Then there's obviously, if the SVR goes up, your heart is struggling to keep up with that same cardiac output. So obviously the cardiac output reduction happens. At this stage, your intravascular volumes get redistributed. Where does it go? It mostly goes to the capillary beds, and the largest capillary bed that you can find is lungs. So a lot of redistribution happens to that. Well, great if it happens to the lungs, the problems associated with it, that it changes the pressures in the different chambers. So the LA pressure significantly, left atrial pressure increases. It increases more than the pulmonary arterial pressures. What results with that is acute mitral regurgitation. Acute mitral regurgitation starts happening, pulmonary edema starts to happen. So now you're making your lungs wet. So that's why we always start to involved in lung and heart transplantation. We always, say bad things about the opioid, the local opioid, the flood the lungs. Yes, they may have to keep the pressures up or giving volumes, but also there is certain things that is not in their hands that's happening at that time. If you look at what are the changes that are happening, the incidence of these changes, most of the common is 80% of them are hypotension, 65% go into DI, and then almost 30%, one-third of the patients have DIC. Arrhythmias start happening about 25% of the time. Sometimes we've lost patients while we are in the OR at the time of procurement that they went into VT. And believe it or not, most of the hospitals that we still go to, small hospitals, they do not have heart programs, they do not have intracardiac defibrillators. It's not there. How are you going to shock them out? So at that time, most of the time, we lose the thoracic organs. Clamp, heparinize the patient, clamp, let's take the kidneys and the liver out. Effects of brain death on cardiac contractility. It's a busy slide, but as I talked to you, what happens is, through the before the slides were showing you, that certain increase in the SVR increases a lot of stress on the heart to decrease the cardiac output. That results in, the fluid which is the blood backing up on the left side, causing increase in mitral regurgitation, causing pulmonary edema. Then there is a phase in which all of those things go down, and then you have parasympathetic activity. Now, because of all of that, redistribution of the fluid has happened. If you look at what histopathological changes happen, so we looked at all these large animal models, we took them back and analyzed them and said 75% of them have varying degree of focal myocyte necrosis, mostly at the subendocardial areas. Presence of mononuclear cell infiltrate leading to edema around the necrotic cells. Contraction bands were noted around the coronary arteries. What happened at the pulmonary circuit? Pulmonary circuit tissues filled with fluids that are rich in proteins with alveolar hemorrhages and disruption of the endothelium. Similarly, there's notice that there was marked reduction of the spaces in the capillary beds of the glomerulus with necrotic and myocardial disruption, so resulting in energy misbalance. Liver, same. Mitochondrial injury was noted, cell necrosis was noted, and most importantly, loss of glycogen, energy stored. This was one of the most, so this was all as a part of the autonomic storm. Now, the second thing that we're talking about is the disruption of the endocrine issues. So, the hypothalamus effects. So, reduction happens significantly of the T3 and T4 levels with unchanged TSH levels, reduction in cortisol levels, reduction in ADH levels, insulin levels. Thyroid plasma profile corresponds to a euthyroid sick syndrome, that is in an acute stress situation like the patients have an acute MI or on cardiopulmonary bypass or severe sepsis. What's happening at the cellular level is that it leads to reduction in myocardial oxygen sources. ATP and CP and glycogen levels are being consumed. What happens because of that? Anaerobic metabolism happens. It further results in reduction in cardiac output. So you already had initially started with that. Now you have endocrine changes that are affecting cardiac output further, stroke volume further, left ventricular pressures. Cellular fuels are no longer metabolized. You lead to excessive progression of ATP reduction and calcium overloads. With reperfusion, these precipitates further PGD. So this is a good way of understanding it. You have 6 liters of fluid in your body, 5-6 liters. And in these patients, you have a lot of things going on. They're giving mannitol as protection. Blood losses may not be going in the donor depending upon injury and things like that. They're losing a lot of fluids in the form of urine because of diabetes insipidus that has started. Then on top of that, now you have the catecholamine surge that happens. It's trying to squeeze this thing. And brain death happens, herniation happens at that time. Now herniation happens, now you have redistribution of all of this fluids that was present into the capacitance vessels. So now all of a sudden you have decreased amount, now it gets redistributed, now you need 10 liters of fluid to maintain the same amount of circulation. So you're already in significant amount of deficit. That's why just to keep up with that, the OPOs have to, or the people that are managing these patients, donors, potential donors on bedside have to give a lot of volume. And as thoracic organ person, we are always upset because you make them wet. As we talked about, most cardiac arrest in brain death patients occurs because of rapid onset of hypotension that occurs post herniation. How do you preserve this potential organs? And I think they have come up with the catastrophic brain injury guidelines. And these guidelines are used to, in patients that have irreversible brain injury, and the purpose is to sustain organs to give families an opportunity, and more important than families, the patient, the donor, because it's his informed consent, his or her, for organ donation. Hypothermia. Hypothermia by interruption of the temperature regulation centers of the hypothalamus contribute to instability due to decrease in cardiac function. Reduces the amount of oxygen that is supplied to the vital organs, obviously, as you all can understand. So the most important is please maintain normothermic temperatures. Bear huggers are sometimes used in these patients. Warming blankets. You may have to use the fluids that you're giving through the warm fluids. Treat hypotension to maintain organ perfusion. You may have to use inotropes. You may have to use vasopressors. If the CVP is too low, then fluid challenges is something that is very commonly used. Diabetes insipidus, obviously you do not put greater than 500 ml for 2 hours, or sodium level that have been greater than 160, because why 160 is as a result of hypertonic saline sometimes being used to prevent herniation in these patients, but obviously did not result in preventing brain death. However, the sodium load was high, and now you're losing all the water, it continues to further go up. DDAVP is used, or vasopressin, at doses that every OPO has decided on in themselves. Urine output replacement therapy, half normal saline to match the urine output, maintenance of the IV fluids. Respiratory functions have to be maintained. Generally, an excellent job is done by the pulmonologist or the ICU critical care. They have to be maintained. You have to prevent barotrauma. You have to maintain proper oxygenation. Bronchoscopies are done for cleaning secretions, making sure that the tidal volumes, actually tidal volumes of 8 ml per kilogram is also not being used. It's a recommendation. Most of the people now have started to use between 5 to 7 cc's per kilogram. Keeping FiO2 settings to the lowest to maintain PO2 greater than 100. I think all of these things are basically trying to achieve the situation where you are before death. You are trying to fight all the things that are happening at the cellular level because of disruption of the axis, the hypothalamus hypophyseal axis. And all of the guidelines that you've just went through are supportive therapy. What is the ideal time? The ideal time is when you have decreased use of vasodilators that are being used, or vasopressors are being used. And if you look at it, the increased inotropic requirements are going up. Cardiac output has been maintained. So this small zone is where you want organs to be taken. If it is higher on this thing, they're very vasodilated. You don't want to miss this window because your inotropic requirements are then going up further. So at the end, I think most importantly is that we should all as a society work towards organ donation, identify potential donors, involving the OPOs, trying to reduce the amount of communication between the physicians and the families. Actually, we thought that we were doing a great job. We always took pride that, hey, we can approach the families. We've been taking care of these patients. We have a relationship with them. But actually, studies have shown we do a very poor job. Actually, OPO have much higher rate of convincing families during this stressful time of agreeing to organ donation. Studies have shown that almost double number of patients will donate if done by professionally trained individuals, and most of them are from the local OPO. Having said that, that was my last slide. Thank you very much for your time.